I'm going to be reading out the many questions that we have here from the audience online. And I'd also like to urge the people who are here in the room to use the microphone here if you have questions that you'd like to answer. I'm going to start with a few online. I'm going to read them out, and Dr. Bailey is going to help hand them out. Okay, so I think a good place to start would be this one here, that CBT has had some success for youth with ASD on the high functioning or Asperger's syndrome end of the autism spectrum area, but not developmental disabilities end of the spectrum. However, for many youth with ASD, traditional counseling in an office is either not an option or doesn't lead to any success. What are the efforts in regards to the service provision for youth with ASD who do not learn to self-regulate through traditional or modified CBT?
Melanie? Or David?
You can chime in. So that's where I'd go to the big B and never mind about the C, and do lots of reinforcing of things like relaxing activities. Every child is going to have in their behavioral repertoire activities that are more relaxing to them. So we encourage them to do those activities, and we reinforce them for doing those activities. And we build those activities into their routines and into their schedules.
I would agree, and I would also, being an optimist, I would suggest that there are always ways that a CBT protocol can be useful with an individual on the spectrum. Often, to me, the downside of some CBT protocols is they are quite manualized and rigid in how you're supposed to work through them. With some creativity, however, I think you can go off page a little bit, and depending on the cognitive ability of the individual, you can be creative and get some good effects, I believe.
Another question, can you describe a bit more about what a psychoeducational program looks like, or what do you mean by that? What is psychoeducation? I think you mentioned that.
Sure, yeah, I did. Yep, for sure. I was stuck on psychoeducational assessment, which I didn't remember saying. Yeah, so what is that psychoeducation step, that sort of first step of treatment for anxiety? So a large part of that is helping children and families learn to identify, well, what is anxiety? What does it look like? So what does a youngster look like when they're experiencing anxiety? It's different for each of us. So my face gets red and it's hard to breathe and I get sweaty hands, but maybe Tony has a different experience of anxiety. It's hard for him to think clearly, or who knows, he giggles, I don't know. So what does anxiety look like? What does it feel like in the youngster's body? What does their behavior look like when they're feeling anxious? And for kids who are aware of self-talk or thoughts, what is the self-talk or thinking patterns that happen when they're anxious? So really just starting there and helping the child and the family and those providing services to them recognize when anxiety is actually happening. Learning more about triggers for anxiety, helping the child and the family and their providers identify a lot of the triggers for anxiety and modifying, well, that gets into treatment, but, being aware of those pieces. What else? Yeah.
I think one of the key features of psychoeducation is, from a therapeutic point of view, helping the individual recognize that a lot of those thought patterns are A, not crazy, and B, quite typical. And that can be quite powerful for the individual when they realize they're not alone in this and that there are standard protocols to support them. So just that piece alone, I find, is quite powerful to let kids know that these patterns are consistent and actually amenable to treatment.
And then helping kids and those around them figure out how to communicate when that's happening. Okay, so maybe I'm noticing that I'm starting to feel anxious, and how do I communicate that?
Okay, the next question. In individuals with ASD and depression or bipolar, how often do we see an increase in self-injurious behavior and an increase in depression or bipolar symptoms?
So I think the increase in self-injurious behavior is much more common in less able individuals. But actually it's quite surprising that people who we normally wouldn't associate with self-injurious behavior, if they're distressed enough, will self-injure, even if they have grown out of it, or we think they've grown out of it. So the history is they self-injured a lot as a child, and as they enter the teenage years, this wanes. And then if the person becomes anxious or depressed again, the behavior can reappear. And it can occur in bipolar disorder. But I think the individual with bipolar is quite often going to be very irritable as well. So it's often impacting on other people more through the irritability as opposed to self-injurious behavior.
The next question on how do you tell the difference between just autism compared to autism with anxiety? I find they go hand in hand and find it hard to distinguish if it's anxiety provoked.
So I'll give Melanie a rest for a moment. People with autism may have concerns about very particular things, as David emphasized. But when we think about generalized anxiety disorder, these are irrational fears about just about everything that's happening to us. So we assume the worst. At its most extreme, we engage in catastrophic thinking. We believe if one little thing goes wrong, then there will be a sequence of events that leads to a very dire outcome. And that is not an intrinsic pattern of thinking in people with ASD. They may be concerned about very specific things relating to their routines and rituals, but they're not extending that anxiety into every part of their life. So the real key here is to try and find out, is the child with ASD anxious about things that previously they were not anxious about?
There's a question here about what is the incidence of depression in children with a diagnosis of ASD? I think we've looked at those figures before, but Tony, in general?
Yes, we showed the data in the first webinar, and my memory is that the rate in children was about 6%, and in adults about 20 to 25%, and the data we showed was BC specific data. So the epidemiological studies tend to show higher rates of depression in pubertal children than the 6% quoted there, and some studies will find higher than 25% rates in adults. But in my experience, it tends to be strongly correlated with all the other aspects of the person's life. So if life is going badly for people, then of course they're at increased risk of depression.
I'd also like to urge people in the audience to stand up and ask your questions. So I think we have Dr. Balbinder-Gill approaching the microphone. Would you like to go ahead?
Just have a question about sensory issues and how do they play a role in children with autism who present with anxiety, depression, OCD.
It's a great question, and clearly there's a strong overlap. When in doubt, I always go to case studies. So there was an individual I worked with who, on the first day of school, went into the school, promptly turned around and ran away and did not go back to school for the first week. All sorts of behavioral interventions, all sorts of therapy. What it boiled down to was the caretaker had inadvertently changed the wax and polished the floor in the gymnasium with a different kind of wax. And until that was figured out, there was no way that we could get past any of the anxiety. So clearly,
And it smelled different?
it smelled slightly different that no one could notice except for this individual. So in that case, it's a very strong indication. And so I think you're right. I suspect that part of your question is we often overlook that part of it. And those sensory drives and needs and sensitivities are huge. Mm.
And I think much more commonly, noise can be a major source of anxiety. And actually that sensitivity isn't as strongly associated with less able individuals as you might imagine. If one asks carefully enough, one finds that often very able individuals will find even common noises that wouldn't upset other members of the population to be quite distressing, and they'll go to some efforts to avoid noise. And of course, busy classrooms can be extremely noisy places, which can impair the child's ability to concentrate on academic things.
Another question here. At what age is it recommended that parents take their children to be assessed for a suspected mental illness? Is the family doctor recommended as a first point of contact, or are there other avenues to consider? Again, we did do this in some detail in webinar 1, but I wonder, Tony.
So even very young children can be anxious. When I'm teaching medical students, I get them to recite the first signs of anxiety, and they're pretty good at recognizing that separation anxiety is a real form of anxiety and can occur in 2 or 3-year-olds. And we can see children with ASD who are obviously anxious quite early in life. Depression can affect prepubertal children, but it's extraordinarily rare compared with post-pubertally. And OCD in the general population usually has its onset in childhood, but I think it's fair to say that often it's not recognized in the first year or two because the parents may not have actually worked out that the child is being repetitive in some way. And obviously it's going to be harder to recognize those patterns in individuals with ASD. So I think the message to parents is that when something changes and it's not an obvious development of an existing autistic behavior, then you should seek help. And I think at our last webinar, Dr. Gill was pointing out that the family physician really is the person who's pulling all the different bits of information together and should be the individual who can recommend to parents where they can seek help for new symptoms.
Another question here is about, is CBT an effective treatment for a preschool-age child with ASD and severe anxiety? So CBT for preschoolers.
Yeah, we wouldn't expect a 3 or a 4-year-old to have the cognitive capability to do any sort of cognitive work. But again, I don't want to be a broken record, but we just come back to the B part. Then we focus on behavior and supporting even very young children to face fears a little bit at a time with lots of support and lots of rewards. We look at what's happening in their environment that we can shift. You want to add anything?
Melanie, would you be able to give the audience a particular recent example you can think of a younger child and the sort of behavioural thing you did?
Ask me some more.
Okay.
Ask me again, and I'll get an idea coming.
The issue here is wondering, I think the audience wondering if you have a 4 or 5-year-old that isn't amenable to analysing their thinking patterns.
What would you do?
What sort of things have you
Thanks,
done?
I got it now. I'm thinking of a young child who I've worked with in the past who was really afraid of using any toilet other than his toilet at home. And so there was some assessment to do to figure out, well, what was it about being in different bathrooms or using different toilets that was contributing to the anxiety. That comes back to, I think, Dr. Gill's question. We had to think a lot about what happens in a bathroom in terms of sensory. It stinks. There might be soap smells. There are loud flushing toilets. I hate the dryers, the hand dryers in bathrooms. There are other people around, lots of sensory kind of elements there. And so we broke it down, which pieces seemed to be the most troublesome or the most triggering for this youngster. And for this youngster, there were three elements that were most tricky. The hand dryer was one of them, and so we did lots of exposure to hand dryer sounds. So that started with just having a recording of a hand dryer. We started it at a very, very low volume. We weren't in a bathroom. You're just gradually, with lots of reinforcement, increasing the sound of the hand dryer. And then once we got to the point where the hand dryer sound was tolerable, then we started using that sound in a bathroom where we were sure a real hand dryer wasn't going to go off, and got the youngster comfortable with listening to a hand dryer sound in a real bathroom. And then we would go to a bathroom where the hand dryer wasn't super duper loud, have the child stand outside of the bathroom with the door open, hearing the hand dryer. Then you take a step closer in, and you take another step closer to the hand dryer, and so on. And so you break it down, and you might have to do numerous, that was essentially an exposure hierarchy. You might have to do numerous exposure hierarchies to different elements in that situation before you get the child to a point where they're actually able to tolerate using toilets in a variety of settings. Is that what you were looking for?
Perfect.
Great, thanks. Thank you.
Well, I'm sorry to say that we have run out of time this evening. And I can tell you there are a lot more questions that are worthy of being answered that have come in. And we will use those questions if there's things that we can answer in a straightforward way, I'll facilitate that. But we will use those questions as part of our development of the online modules to get a sense of what people are interested in. So if you have additional questions, please send them to info@actcommunity.ca, or you could send them to your contact, the emails that you've been getting from UBC Continuing Professional Development. I'd like to remind you all, those who are doing this for continuing medical education credits, to fill in the attendance form. The link is here, and it will be sent to you again. So attendance form, evaluation form. We have been working quite a lot on the team, bringing together resources. We have put these resources on a web page that ACT's developed, and you'll see the link here. And the idea is that we're also open to hearing about your resources, things that we might not know about, to add to them. And that's continual at ACT. You know, what we have, we rely on the community often to provide us with the latest and greatest things that you're using in the field and that you found useful. I want to remind you all that ACT provides individualized information to families and to community professionals by our information officers. We do it in English, Chinese, and Punjabi. Here's how you can get hold of us across the province. We have lots of other resources that I don't have time to mention, but this webinar will be available in about 2 weeks' time online on that same link. There's also a survey that we would very much appreciate everyone in our online and live audience filling in, because we need to know more about, I think David pointed as well as Georgina, to the resources that are not yet developed. And I have found in this province that actually, if the community articulates what it is that is missing, that there's a great deal of responsiveness. But we do have to have the ability to articulate our concerns. So ACT is committed to taking feedback from the surveys and from the focus groups we've done as part of this process, and to put them together to try, with the advice of our advisory group, to put them together and to think up some strategies And as we find out about new resources, we will post them for the community here. So in 2017, we're looking forward to developing online learning modules, and we're hoping that we'll continue our relationship with UBC CPD that has been such a great help to us. And thank you all for your participation, and have a very nice evening. Bye-bye.